Good evening, one and all. Today is the second day of our online workshop. I think yesterday was a very good session by Dr. Arun Kumar. He really got through the basics and he made us realize the importance of knowing the NGS testing, what we are sending, what is the assay, what is the platform. All these things very well it was explained yesterday. And those who want yesterday's recorded session, please, you can always ask us. Probably we'll send the link, recorded sessions link live, whatever we are recorded to your email. So you can send a personal message or post in the WhatsApp that you want the recorded session. And if at all you want to see the recorded session, it will be during the workshop time. So after that, if you request, you may not be able to we may not be able to provide the recorded session. So with this, we'll go on to the next session for today. It will be by Dr. T. Raja. Hello, sir. Thank you for joining. You are able to hear me, sir?
I'm able to hear you, Dr. Arun. Good evening.
Thank you, sir.
You
It's
are
a
able to hear me?
Yes, sir. Absolutely, sir.
Okay.
Most of us are in Indian Society of Oncology in Mangalore. I think me, Kripa Shankar, all of us are here. So it was a good session. It is nice. Almost some 40 persons are there in the workshop. 40. It's a mix of the cohort is a mixed one. Predominantly medical oncologists. Some are radiation surgical oncologists. And there are some PhD scholars and pathologists too in this particular cohort for this workshop. So it's our privilege to have you here, sir. We would like to learn from your experience, vast experience you have in this precision oncology in particular. To be honest, actually, the sir, when I thought that precision oncology conference we should do and a workshop particularly we want to do, the first person I really thought was T. Raja sir, because last 20 years we have evolved actually. Initially during my DM times, all the cancer we are giving same regimen, same chemotherapy schedule. Slowly each cancer we stratified. Each cancer was grouped, so different stratification, and we try to give according to the risk. We treated the patient. Now we have gone to the personalized era where every patient has a different genotype, and we treat the patient based on the genotype. So today we can tell for sure that precision oncology is not the future, but it is present. But 10 or 15 years back, when I thought it was the future, I know sir was practicing day in, day out in a real world scenario. So that's how when I thought of this precision oncology, the first person that struck my mind is T. Raja sir, and we can learn a lot from his experience, particularly how he used the data in a real world setting, because many times when we order a NGS, we have more questions than answer. That is a problem. So at the end of the day, when we see the report, we have more questions than finding an answer. So how all these things evolve, how he practice over a period of time, how he use these data, translating into patients' benefit. So introducing Dr. T. Raja sir is a privilege for me. And he is well known. He's a pioneer in many aspects of medical oncology. He's the director of medical oncology Apollo Hospitals. He's head of DNB program in Apollo Hospitals. He's adjunct professor in medical oncology, and he has numerous awards and publications to his name. So with this, the platform is over to you, sir. We are here to learn from your experience. Thank you. Thank you very much, sir.
Thank you, Dr. Arun. It's so kind of you to invite me, and it's an absolute privilege, honor, pleasure to be here with you. And I'm really excited. I hope that can somebody allow me to share my slides?
Sure, sir. Sure.
You have to allow me.
Sure.
Tell your people.
Yes, yes.
So first of all, very formally, thank you so much for inviting me to be here. And I hope that whatever I think I will be able to share to this fraternity. Nowadays, as Dr. Arun, what you mentioned, I myself see that there is a tremendous change in the medical oncology community. I really see the youngsters now to be, absolutely well prepared, and I would say the one word, many of them are already very, very excellent. So I hope that I can add something to them with that preamble. Okay. Now, as one of our very famous scientists would say that what is the difference between practice and theory? Um, in theory, there is no difference between theory and practice, but in practice, there is the difference. So what I'm going to do is I'm going to touch upon a little bit of theory, and then I'll see how it works out in the real world, some patient examples, and then come back to a little bit of theory. That's how I thought I'll make it. I can transfer what I think, that this is the way. I would urge you all to read this particular article that had appeared just very recently, ESMO Precision Oncology Working Group Recommendations on the Structure and Quality Indicators for Molecular Tumor Board. It's a very good read, and I've given the reference here. Basically, it talks about there is a patient sample collection and validated genomic report, and it goes to MTB discussion, and what does the MTB recommend, and how do we put into clinical intervention. It's a working group. It's a very broad. Probably they have in their mind a large community, including low and middle income groups. So it's a good read for all of us to understand what the Europeans currently think. Basically, the recommendations are like they are talking about who should be part of the MTB, what should be the composition, minimum requirements, and then they also advise us. I have only focused on some of the excerpts they have given. I'm not even going to exhaustively read into this, but they try to tell us which cases you should focus. For example, it should be a complex genomic profile or unexpected findings, rare cases. And they are saying that when there should be a concern, when there need not be a concern, and then what exactly the treatment recommendation should focus on. And so it's a good idea and a good read to read that, to understand what a large group of European and mixed faculty thinks about it. And then how does the workflow happen in a precision oncology clinic? There is always a patient where there is a need, and the standard therapies probably are not enough to answer the question, and then they go through the initial evaluation, pathology, radiology, and then we select that this patient should have something more, and then goes into a precision clinic, probably an advanced patient. But nowadays we also look at a lot of early stage patients and patients who have probably passed on 2 3 lines of. These are all the profile of patient that is commonly discussed in a precision oncology clinic. And the patient goes through a counseling that such a test is going to be done, and why do we want to do a test known as genomic profiling, and what is the use of that particular test, and how much time does it take, and all that, what is the cost, and once the report comes, then again whether it's a validated test, and what does the test say, and then how do we really understand the reports of the test, that's known as molecular curation. And then finally, after the test results are available, it just goes to the molecular tumor board, which is multidisciplinary, and everybody should be there, and everyone should participate in the discussion, and a combined decision making is made, and treatment decisions are done. And finally, once the treatment decision is done and incorporated on a patient, you continue to monitor. This is the workflow, what happens in a precision oncology clinic. Let's see what a major hospital tried to do, and see what did they achieve. That will be a good learning for us. Memorial Sloan Kettering, 2011, what they did is they created established this profile of genomic assay, 505 genes. That was what they originally started. That was known as MSK Impact. That was started in 2011, and it took quite a while for them also to understand whether this is a good thing to do for patients, and they went through the approvals and all. It'll be really curious to learn that such a big hospital, iconic, and we think it is the top of the line, and they took several years to finally say that we have to adopt it. That's important for us, so we don't have to feel shy or inhibited where we are, considering what they went through just a decade ago. Only by 2020 they started settling down on this, and then they have collected about 50,000 patient profile, and then on around 68,000 patient and 86,000 tumors. And there, why I mentioned this particular slide is that this is when they moved on faster. That's the learning point. Then what they did, they did this OncoB. The OncoKB was actually incorporated in 2010 and 11, and it was basically driven by an Indian, one Indian lady. And this is their database, knowledge base, and this was FDA approved. This is OncoKB. All of us now can refer this. And then what they did is they started to offer this comprehensive diagnostic assessment to every patient. That's the point. Then they started to assess, put it to every patient, and then they started to look at mutations, gene amplification, deletions, and then they kind of collated the whole thing. This is how the report looks. And today, in 2025, what has happened is they are able to now annotate 7,500 alterations across 820 cancer-associated genes. So that's where they have arrived. And they have then connected with the AACR, and now it has become a much larger database. This is again 2 years older. They have crossed more than 15,000 tumor profile. And now what did they finally derive out of this is that once they become bigger, then they ask the question, how much I'm benefiting the patient. To date, they say that to the tune of around 69% of the patients will have at least one targetable alteration. So that's a very important takeaway message, because I'm going to refer to some of the publications from our own friends and fraternity to understand where the MSKC stood a couple of years ago, understanding. Then what did they do? They then integrated this genomic profiling into OncoKB. Then they took it forward, and then they kind of integrated that to their targeted therapy trials. I think this is where they moved on very fast. So these MS cases, impact results, OncoKB, and then they went into the targeted trials, and that's where they caught up with over time that they couldn't catch up earlier, and then they also then moved on to basket clinical trials, where whereas the targeted trials would be on a specific gene mutation and a specific intervention, then basket trial would be where a single particular alteration across the different tumor types, and now we all know that n is to 1, all that has come into picture. Then again, this is a then it metamorphosized into the iPredict study, in which multiple centers, multiple institutions, even some of the pharmaceuticals, they all got involved. And then this is a combination therapy. Until then, it was a single intervention, single mutation. Then they went into a combination therapy. So that's the iPredict study. And finally, what is the iPredict study trying to tell us? That there is a real difference in the PFS and in the OS with this approach. And this is 2019 or 2020. This is where the Western world have arrived. And now let's look at, what happened in India. This is in 2020. Dr. Aju Matthew, Dr. Nirmal Rath published that only 4% of patients who underwent comprehensive genomic profiling would benefit clinically. And then our own Dr. Prashant Ganeshan and the group again published their real world experience and said that only few alterations like the BRCA1, BRCA2 are important, actionable. Rest are all still not very useful. That was the kind of impression they delivered. And this is another data from Dr. Bhavna, again saying that in the low income group and middle income countries, precision oncology is still not take off. That's the kind of sense we got at least 2 3 years ago. But I'm very very glad to say that things have completely changed across the country. There is no doubt, and the next generation of our oncologists have completely caught on with this. And precision oncology, as Dr. Arun Seshaswalam just mentioned, it is not a future; it's already present, and absolutely. And I see that everybody is many of them are very comfortable in what they are practicing. Again, there are challenges in the Indian scenario, so trying to balance here financial toxicity, availability of resources, and the drugs per se cost, and ethical consideration. The other biggest problem is we are still not able to, fluently integrate into the clinical trial scenario where we find something which is rare and unique, but we are not able to convert those patients into clinical trial scenario. I think if that happens, then the next big jump will come in India. That's what I believe. Now, now this is a theoretical, introduction that I have given, but then let me now take you into a little bit of practice and how does it all convert into case, on the real patient basis. So I want to take you back, at least 25 years back. So this was published in 2001. March 2001 was the publication by Dr. Dennis Lamon on the use of trastuzumab in patients who overexpress HER2. But I think this is where the real journey of precision oncology started. Again, in April 2001, Dr. Brian Drucker, he presented this in 2001 ASCO, where he showed that tyrosine kinase inhibitor in chronic myeloid leukemia. Solid tumor, liquid tumor. Around the same time, around in the year 2001 and 2, the trials on JD 1839 started on CA lung in patients who have progressed on standard chemotherapy. And you could see that the drug caused dramatic improvement even after a few months. This is one of those early patients of JD 1839, which later on is the IRESA, or the gefitinib. And this patient is one of the early patients of the clinical trials. Many of you would have seen this picture, and she was or stretcher or wheelchair bound, and this is the grandchild. She is dependent on oxygen, but she was put on this drug in 2003. She's dramatically better, and the child has also grown up. And this is one of the iconic images and iconic patients which really convinced the world that targeted therapy is there to stay. And this is a 2003 and 2004 publication of gefitinib. So why I'm presenting that here is, so we had a patient in 2001, and she is a carcinoma of the lung. She went on to receive standard chemotherapy at that point in time. She had a good response in 2002, but then again she relapsed in 2003. And at that time, we put the patient on second line, and she did not respond to second line. And one of the son was living in US, so we could talk to the, FDA and the company, whatever, and we could get IRESA on compassionate basis in 2003. And this is the response in October 2003. And this lady went on to live for several years. And that really caught us hooked into this kind of approach. And we really thought that this is the way to go. Another example, this is a patient in 2007, late 2007. He was a very busy executive, and he had this florid lung. And you all would have seen many patients like this by now, but this was in 2007 and 8. And at that time, again, he was literally in the ICU on the NIVs, and all that one did not respond to standard chemotherapy, and then he was put on gefitinib. By the time, fortunately, the generics have arrived, and he was put on gefitinib. And you can see that he had again a dramatic response. He went on to live for several years. So these patients really told us that this is the way to go. I mean, at that point and in the near future. This is 2009 publication by Dr. Gasdar on personalized medicine. That's the time for personalized medicine or personalized oncology. The term itself came into vogue. And 2009 ASCO plenary session was personalizing cancer care. That's the first time the ASCO itself coins this term, that personalized cancer care. In 2014, in our hospital, we established the DNA sequencing and RNA fusion primer sequencing, and we started doing these assays regularly for our patient. And it was, very these are very early days at that point. And this is one of our patient on first line osimertinib. This is somewhere in 2017 18, and you could see that the patient had dramatic response. You now have, many of you have such patients, but the point was this was several years ago. And look at this dramatic response that really convinced us that these are all the way to go. Then we also established the PDL1 as a biomarker way back around the same time, and this patient had a TPS of 90 to 95%. And once again, a single agent pembrolizumab. This was again, several years ago, with a very, very excellent response. Then we moved on to comprehensive genomic profiling for our patients, and we started doing comprehensive genomic for most of our patients. And what would a CGP tell us? Gene fusion and either insertion, deletion, or a copy number variation, and a single, so on and so forth. And then we started appreciating whatever we see in the Western literature. This is a patient who had dabrafenib and trametinib response to CA colon, and this is a patient sarcoma who has got a she's on entrectinib, and the NTRK demonstrated entrectinib and excellent response to entrectinib on the third line. And this patient had a PDL2 in the NGS in CA ovary, multiply treated, did not respond to anything. Single agent pembrolizumab, dramatic response. And this is a patient who had a RET mutation, in RET fusion, and this was in 2021, 4 years ago. Pralsetinib, excellent response. And this is another patient, selpercatinib, excellent response in CLung. And these are selpercatinib response. This is in 2021 and 22. And then, once we started doing comprehensive genomic profiling in most of our patients, it started to throw up and some difficult and uninteresting situations. And this patient, sometimes you don't have an answer when you have the report, but that doesn't mean anything, except that over a period of time, these things will happen, but you continue to learn. This patient had a pathogenic exon 18 deletion. This was in 2019. We simply did not know what to do at that point. And this patient, again in 2020, had an EGFR kinase domain duplication, very rare. Only a few patients have been reported, with this alteration. And then this patient went on to show excellent response to osimertinib. But this is one of the rare patients, so we have tried to write it up and send it across. And the patient is still doing well now, 3 years down the line. And this is a patient of high grade, ovarian cancer. This is in 2018. Already multiple lines treated, progressed, and at that time, profiling would show that the patient had an alteration in FGFR1 and 2, CDK4, CCND1. We don't have anything to target FGFR1 and 2. CDK4, CCND1 was very attractive to us. We took a chance. We put the patient on palbociclib and letrozole in 2018. And you see that the patient has an excellent response, 2020. And the patient is still alive, still doing well. And now we have, after a few years of palbo and letros, we have now taken off everything. She continued letros for some time, but she still continues to do well. A couple of patients on exon 20 alteration, and this is a lady who was again many lines treated. She was diagnosed in 2019, many lines treated. By the time she arrived in 2022, she had already crossed many lines, and we did profiling, and we got an EGFR exon 20 insertion on her. And then this we put the patient on, this is one of our early patients on amivantamab, And I think we got it on at that time. Initially, there was some compassionate use allowed, and then later on, it converted into to market availability and dramatic response to amivantamab. And she is still doing well. She has already crossed nearly 3 years. And this is another patient. Based on this is another patient who again, this is a gentleman. The profiling in 2023 shows EGFR exon 20 insertion, and well-meaning families. One of the brother is a physician in US, so we could talk to him. This is in early 2023. So this patient, we had put the patient on amivantamab plus chemotherapy in first line, and you can see the dramatic response to amivantamab and chemotherapy, and and I mean, these are after 6 cycles. The patient had brain lesions, and even the brain lesions have resolved, which was previously not known about amivantamab, about the CNS efficacy. We could see the patient is still doing very well, and this is even before in ESMO 2023 the Papillon and the Mariposa data was presented. But this patient, we could start based on our discussion with the patient family, and we could show that the patient had a very useful response to amivantamab early on. So these are very exciting to see that how all these things helps out to our patients. And this is another patient where this was way back in 2018. When we did CGP, we could show that the patient has an exon 20 insertion. At that time, none of these drugs were available. No amivantamab, no bombesidimab, nothing was available. So what did we do? We put the patient on afatinib. The patient progressed on afatinib, and in 2020, we did another liquid biopsy, and that liquid biopsy shows that the patient has developed T790 mutation. This is on exon 20 insertion, treated with afatinib, developing a T790. Those are all very rare. At that point, we didn't have data what to do, and so based on some real world evidence, and we had put the patient on osimertinib at that time, and you could see that the T790 disappeared, and the on treatment, and the EGFR exon 20 insertion again reappeared with an increased VAF. So this patient taught us what it means to longitudinally monitor with liquid biopsies. And I will also show one more thing. This patient, this is a solid biopsy of the foundation one. At that time, the foundation one did not have liquid biopsies. This is a liquid biopsy of Gordon, actually, that because they were the only one who were having liquid biopsy, and this is how they picked up the T790. And this is a liquid biopsy for foundation one. That's when the liquid biopsy for foundation one itself was introduced, and all of them show the same variant, so that validates that. But one more important thing is something that we completely missed over the 2 to 3 years of this patient. This is a particular variant. Just see here what I'm trying to show. I hope this is visible to you. That's known as NBN. There's an NBN variant that is seen here. You also see that this NBN variant was found in the first NGS report also. At that time, this was reported to be of 49% of VAF. We did not even know what it is. We did not look at it. But then down the line, we clearly see that the NBN has the VAF has increased. Then we later on learned that this is a very rare patient of Nijmegen breakage syndrome, and that is one of the causes for CA lung. This patient was a real learning in two things: that longitudinal monitoring, and then what we don't see in the given CGP. So that's what this patient taught. But then again, you see a lot of other reports where, I mean, it's not easy when you see a CGP like this, and so much of changes, you don't know what to do. Today it's fine, it's very easy, but this was in 2018. And what finally caught our eye is that this is a patient of CA colon who has already crossed about 5, 6 lines and has already undergone 2, 3 major surgeries, and was treated here in Chennai, Mumbai, everywhere. And what we saw here is a tumor mutational burden of 51, which is very high for a CA colon. This was in 2018. Just then in 2018, the FDA approved agnostic use of pembrolizumab for high TMB. So based on that, we counsel the patient, put the patient on, and he's a young man. He was in his early, late 30s and 40, and he dramatically responded, and he is still doing well. And then after 4 or 5 years, we had to take him off pembrolizumab. He's still doing well. This is another patient. Look at this complex genomic finding. Nobody knows what to do with all these things, but then we sit down and talk about it, analyze. That's known as reductionist approach. This is very, very important. You need to finally deduce each of this, try to put some sort of a idea behind this, and see that AKT2 catches your eye and RAT21 catches your eyes. You look at all these things, and this patient actually showed this is an urachal adenocarcinoma, did not respond to, gem combos and also oxaliplatin and folfirinox. He did not respond. Finally, the patient responded to PARP inhibitors. And then he went on to be, up till 2023, he was okay. And then newer technologies came in. ctDNA, we routinely started using liquid biopsies. And this is a ctDNA of our in colon patient profiles. And we now also start doing RNA expressions and circulating tumor cells. This is a patient we saw in 2020, and pancreatic cancer, again, a locally advanced disease, and had, I think 1 or 2 metastatic site, but inoperable, did not respond to first line chemotherapy on NGS. And this is a very high profile patient, elderly man, and the NGS showed a very high TMB. And this patient then showed an excellent response to pembrolizumab. And this patient, we had started following this patient on circulating tumor cell and ctDNA since 2020, 2021. And you could see how the CTC evolved. And finally, when we saw clinical and radiological remission, it dipped down to 0, and that is in 2021 December. The scans are good. CTC is negative. Right now, we have now done about 36 to 40 follow-up CTCs on the patient, and the patient is continuing to do well. Now has crossed about 4 years, and the patient is still in complete radiological remission and clinical remission. And therefore, now we do believe in ctDNAs and CTC, and we do intervene. This is an early colon cancer patient whom you would have normally observed the patient. This is basically a stage 2 disease, but on ctDNA positive disease, we decided to act on the patient, put the patient on adjuvant chemotherapy. This is a patient of osteosarcoma, where we used a bit of bioinformatics and intervened, multiply treated from August, from 2019, and has crossed about 4 to 5 lines progressed. And then when we did the whole exome sequencing, we could also get the help of the provider to get a pathway analysis. And after 5, 6 lines of therapy, the patient had this suggestion from the pathway analytical team based on bioinformatics that the patient should be treated with bevacizumab, ifosfamide, and regorafenib. So what I did, I also took a second opinion from Dr. Banwali, and then he said, "What else you can do? Please go ahead and do." And we put the patient on that combo, and after 5 lines, and very, very, very useful response to that kind of combo, partial response. The boy went on to be doing well for about 1.5 years, but unfortunately, late last year he progressed, and we couldn't do anything beyond that. This is a gentleman who had prostate cancer, 2019, and look at his presentation. He was treated elsewhere. He is an international patient, treated elsewhere. He lands on us. He presents with dramatic disease in the lung and the scrotum testis. You could see a deposit. That was also removed and tested. All prostate cancer and bone disease also. And treated with lines of hormones and docetaxel, whatever, darolutamide, cabazitaxel, progressed, and then developed further nodules. At this time, we did an NGS on this patient, and we see that the NGS showed that there is NRG1 overexpression. And what is NRG1? It's a fusion and it's a neuroregulin fusion. These are very rare changes, and but this is also now captured in some of the malignancies, and this is 0.25% of non-small cell lung cancer. It can happen in other malignancies also. This is the physiology, and it actually hits the EGFR domain, and this is the pathophysiology where it really hits the HER2, HER3 dimerization, and a lot of work is being done. This is a very important drug known as genokituzumab, and this is the first-in-class drug for this particular target, but it's absolutely not within our reach. Each shot costs around 12 lakhs, so the patient 50, 70 lakhs of projection, nothing can be done. So what can we do? We tried again, we went back to our reductionist approach. We tried to really, dissolve with the various findings and tried to arrive at, and then we put the patient on trastuzumab, pertuzumab subcutaneous, combo, and to our pleasant surprise, excellent response. And the patient still continues to be in good response. This is another lady who is a CA lung who had gone on to progress on osimertinib and then PEM carbo plus osimertinib. These are the variants. This is an NGS done in 2023. So shows a change in the EGFR 21, that is L858R, and then has a co-mutation in EGFR exon 20 and has got a TP53. So these are very difficult to, look at where these are all situated. These two L858 and this exon 20 insertion are actually very close to each other. They both still sit on the tyrosine kinase domain. And this TP53 variant is also a very, very gain of function mutation, very, very active mutation. Therefore, it continues to confer resistance. The patient went on to develop after a year, they went on to develop MET amplification. And then what we did is we put the patient on a combo of osimertinib and capmatinib, went back to that, and you could see that the patient has shown an excellent response. Again, this is all known as, sitting down and trying to crunch it. And I mean, if you look around, there is some support literature, but sometimes you don't get any support. You really have to really, talk to the patient, explain to them the limits of data available, and take them into confidence and see what we can do. This is some about of examples I've quoted from the patient experiences, but then I'll come back to quickly to the some of the theoretical importance of it. So I won't bore you too much, but this is what NGS report should contain. It should contain. It should talk about what level of evidence that it is. I mean, now the NGS report should talk about this. Either they should quote the ASCO cap level of evidence tier 1 to 4, or it should talk about SCAT 1 to 5, it should say, or OncoKB. These things are essential. This will help you to decide which are these changes are important. So why I present that is that for example, in lung, if you see EGFR, AL, KRAS, G12C, so what is the level of all these societies or guidelines agree on a particular intervention? That is known as the level of evidence. But then again, the same mutation, if G12C is seen in the lung, that's a tier 1, level 1, tier 1 evidence. But if the same G12C is seen in breast cancer, ovarian cancer, then the level of evidence is totally different. This is what you should understand. So the same mutation, different tumors, the level of evidence, what is available is different. Again, when you read an NGS, you also try to look at things like what exactly they are reporting. What is that they are reporting? Are they reporting the CNV, SNV, indels, fusion, splice variant? And then what is the actionability evidence they are presenting? That's very important. What is the coverage they are talking about? And another important aspect is tumor content and purity. That's a very useful parameter. And then, of course, now a comprehensive profiling should give you the TMB, MSI, and these are all HRD signatures have come into play. All these are very important. It should be there in a good quality report. So that will help you to make decision. To complicate matters, now apart from DNA sequencing and RNA sequencing, now people are talking about proteomics and transcriptomics, and single cell sequencing have already come into picture. And this is one of our own patients. Now we start to do this a lot, and now we have about more than 50 patients profiled on single cell sequencing. This is one of our patient, one of the very early patient, where in a single circulating tumor cell they could demonstrate a PDL1, and this is published. And so now single cell sequencing is catching up in a big way. And again, for all this data crunching, artificial intelligence and machine learning is already there. But then again, I want to simplify and say that it may look like there is so much of data points, so much of extensive aspect of this, but the simple thing is, it is all in your own satisfaction when you try to do a little best for your patient, and then it's a little bit of crunching, but it is also fun to dive into this molecular world. So that's what I can tell you. Hopefully, I was able to convey a little bit of my thoughts to all of you. Thank you so much for listening to me.
Thank you, sir. It was wonderful actually listening to your lecture. Nicely you summarized like some 30, 40 years of experience. Nicely you put up in half an hour. Lot of patient data also you put how unlabeled indication you started amivantanib and the data came later. So I can see how exciting it would have been. Like you start a patient on unlabeled after discussing sad decision making. Later a big data comes which proves that you are right. It's wonderful. This platform is open for discussion. Any questions you want to ask, sir? The platform is open. Okay. I will start with my like when you the precision oncology clinic, one of the setting the most important precision oncology is the molecular tumor board. In that molecular tumor board, although routine tumor board, all of us will be there. We need to add genetic counselor and molecular biologist. So how you started initially, because getting a molecular biologist on board and making them understand, because many times when you show the NGS report, the recommendation what they give, many times it's not practical. So even sometimes when you give multiple agents, they will try to like EPO, NEV plus PAL based. So combination they will try to give, which may not be possible in our day-to-day practice. So initial when you started your molecular tumor board, how did you handle this, and what is your thoughts on this?
Arun, thank you for asking the question. There is nothing like we tried to um, we tried to say that this has to be done in this way, or it was not a very SOP driven way we did, very frankly speaking. It was all like the excitement of doing something new. And then, along the way, you learn. One thing that helps is whenever you have the teaching program. I mean, even though you are in a, if we even if we happen to be in a different setup, but once we have some teaching program, and once we have the postgraduates, I think that's a big help, because the whole atmosphere becomes, wherever you are, it need not be. Now the academics have is not necessarily within this temple of academic institution. It is moved on, and once you have younger generation of people, student, it's a big help. But then, how does it happen? I mean, you need your the medical oncologist, and then pathologist, as you rightly said, and molecular pathologist. That's where the key, who should be interested in profiling and all that one. And then if you have a molecular biologist, And now they are all, I can tell you, now more and more people are coming up in that field, and there are now some excellent people already available, and their services are available online. So that was all not available to us when we tried to do all these things. But fortunately, things have changed. Molecular biologists are available. So basically, molecular biologists, medical oncologists, and then organ-based specialist. You start somewhere, and then within few months, you see that everything is happening. That will be my advice to you.
Thank you, sir. Thank you. Actually, this whole program we designed so that we'll bring research scholar also into it, so that we'll have scientists and PhD scholars also into this program, so they can see what we are doing, so we also can see what they are doing. So we can provide a platform where a researcher, pathologist, and oncologist come together, particularly, which will be very useful as far as precision and oncology is concerned. So I think Siddharth is rising, has some questions. Yes, Siddharth, over to you.
Sir, I want to ask regarding the validity of the tests that are being done by that by many labs. So, like the tests that are being available at variety of prices, and as you have said that initially when this was being developed, there is a validation of tests that needs to be done. So, how to know that whether that private lab has actually done the validation of the test, or we can rely on that the report that is being given?
Okay, thanks, Dr. Siddharth. I can give you a practical answer on that. Fortunately, things have changed over the past several years. And when we started off, we were repeatedly asking the same question that when anybody came and presented that we will be able to do this test for you, and this is the number of genes that we can test and all. Immediately, the question that we asked is, have you validated this? That will be the question that we asked. But now I can more or less reassure you that even in our country, many of the labs are now providing, I mean, absolutely very standard outputs, I can say. What is the proof of pudding? Two answers. Uh, what is the proof of pudding? So you have a genomic alteration, let us say something unique, and then you put the intervention on it, and then you act on it, and then you see the dramatic response. Then that tells you that the test is right, your intervention is right, and you see. So there is nothing more convincing than actually seeing the best result in a patient, that the test is right and you acted right and you got the result. This is one answer. But then one anecdotal experience is not going to convince yourself and everyone. But when you have patients and several patients, and then you act with faith, and then you see that they are showing the response, then you realize that this is all correct. But then again, you can't be sending a test to everybody and anybody, and so you try to narrow down to few good labs and then settle down with them and work with them. I can assure you that some good labs are there in the country. They are all doing a good job. The second answer to your question is different. That is from the bench. Fortunately, what happens is, even though all of these, let's say, companies are offering you the test, it's not that they invented the test. They don't create a platform like what MSKCC tried to do. They all buy the platform from a common source. That's the for example, Illumina platform. They all buy it, put it, and then they try to just turn the test on. That's what I can tell you. For example, all of them buy the same washing machine, and then everybody can operate. A very educated person can operate, or an uneducated person can operate. And if you are given a very very good laptop, anybody can buy. And if you have a good PPT, a very educated person can do. So I think it's all set. That's the second answer. Most of them are using the, if you see all of them providing the test, all of them have got the platforms from similar sources. So you can take it that most of it is okay. But then again, use few things, few of the labs, and then try to acclimatize with them. Once you have your trust factors, you are okay. The trouble comes DNA sequencing is all now very old set technology. You don't have to worry about it. It's all there. But then the trouble comes when you start to move into RNA expressions and all that. Many people are still struggling. So let's wait, let them all settle down and give us a very reliable kit, and then we'll take it from there.
Thank you, Raja sir. I
Regarding,
think
sir, sometimes they said they have done it on Illumina platform or Thermo Fisher platform. So is
Exactly.
there
Two major platforms that are, this is nothing like a Honda car and a Toyota car. So you would agree when I broadly say that Honda and Toyota, something like that. For example, two major ion torrent Thermo Fisher platform and Illumina platform. These are very standardized platforms, uh, from which all of these, many of them buy from. Only few, only few of them are now developing their own kit, and they are then trying to turn out the test on them. So you look at them, look at their lab, and then if you familiarize with them, if they are good, you look at their publications and see. So, but most of the others are using standard kits and standard platforms.
thank you, Raja sir. Actually, very practical answer you gave. I think which we can use in our day-to-day practice. Some two, three small frequent questions that come to us. It may be used to all young medical oncologists. How frequently you send an NGS, like for a metastatic cancer? Every time patient progresses, you try to send, or when they are not responding to a conventional treatment or standard of care, they are unusually responding. That is the time you try to send the NGS. Or what in your practice is? Do you have any algorithm when to send NGS?
Ideal answer in the metastatic cancer setting, and also in patients who have progressed on, I mean, let us say standard lines. We try to do a comprehensive genomic profiling for all our patients. That's the ideal answer. And again, even in early stages, now with all the currently available approved indication, you now have adjuvant approval for osimertinib, adjuvant approval for many of these targeted therapies now. So your indications are increasing by the day. Having said that, I mean, even in a very tertiary hospital, even in a big corporate hospital, it's not possible to convert every patient and do it. So that's a practical reality. That's where the indications and the cost are intervening. But the short answer is that most of our advanced patients and patients who have progressed on the standard lines, apart from the early patients where there are specific indications, most of our patients will be sent on NGS testing.
Okay. Thanks, sir. The next is when we send a NGS and we get a mutation, which is tier 3 on SCAT, where we know it responds in a cancer, but we are dealing with a different cancer. So that kind of report we get quite often. For example, PIK3 mutation in a colon cancer, or PIK3 mutation in whether to. So how do you extrapolate the data? How comfortable you are? What is your experience?
We There are I can say two answers. One is that there are some of these mutations which are agnostic. Some of the mutations cut across and work anywhere. You have your RET or NTRK. It works wherever it is. It works, and then, but some of these changes are not showing the same response across different tumors. That is also well known. For example, if you take the HER2, it is well known that the responses are not common across the various spectrum of solid tumors. So therefore, but on the other hand, some mutations, even though it is rarely heard about, it works exactly the same across all the solid tumors. So there are some tumor agnostic, like interventions, there are some tumor agnostic mutations which are which respond across. Some of them don't respond. So again, it's just a question of, as time goes on, as literature comes in, you learn that the PIK3CA works well in some tumors, but it doesn't work in some. But having said that, I have used PIK3CA in CA colon. That was even 3 years ago, and I have a patient who has responded. But then again, I have also seen patients who have not responded. So the response is not uniform. The reason is we were trying to look at why of that. What we realized that is that mutation is not, it is sitting in an environment where there are other things. There are the tumor microenvironment. There are all those lymphocytes, different lymphocytes, and that particular environment in that particular tumor, even if that driver is sitting, there are other things that are taking care, which are not allowing the intervention on that particular target to be as effective. So the tumor environment is heterogeneous, and therefore the interventions don't work everywhere the same. It's continuous learning.
Okay. Fine, sir. Thank you. I think any other question? Otherwise, I will ask last one of my questions to sir, and then we'll close the session. Anybody having a question can raise a hand. Otherwise, this will be my last question. The circulating tumor cells, particularly in colon, like a lot of data is coming. So, how are you using, sir, in adjuvant setting and metastatic setting? Like, what is your practical?
At this point in time, the problem is, as long as it's a metastatic disease, you're okay. You can use them to monitor and see the response, and then if they disappear, you are happy. So there is a bit of a correlation to the outcome, to what's happening with the circulating tumor cells and the ctDNA. There is a bit of a correlation, but then to be bold enough to act on some pristine areas like early disease, that's where the trouble comes. Then you need to have some data to support you. For example, in an early colon, whether I want to intervene or not based on a ctDNA finding, if you ask in a forum where there are very, very senior, good, GI oncologists, you will be surprised to see their dichotomy of opinion. The trouble is, once you treat a patient, if the patient cuts across and goes to somebody else, and they may give an opinion which is so you need to be also practical. You need to be watchful around you. But as I told you, as I presented, when you talk to the families or patients who are initiated, then these are something that we do believe and start acting. That's what I do.
Thank you, sir. Thank you. It was excellent listening to your lecture. Enjoyed it. Learned a lot from you. Probably a lot of young medical oncologists here would have been inspired. I think, as I rightly said, right, precision oncology is the present. It's no more the future. And I think we need to personalize the care to the genotype of each and every patient. That's where we are going. Thank you. Thank you very much, sir. Thank you for the evening.
Thank you so much, Arun, and thanks everyone for joining today.
Thank you, sir. Thank you. Thank you very much.
Good night.
Fine, sir. Fine. Sir. Thank you.